Midostaurin's been approved for the therapy of AML since early 2017. And around the time that the data were presented, everybody wanted to get midostaurin, but it wasn't quite yet commercially available because the phase 3 was known to be positive, but the drug hadn't gone through approval from the FDA just yet. So at that time, the manufacturer of midostaurin, Novartis, had created a expanded access program and made the drug available to patients at a number of centers, including our center at the University of Pennsylvania. And so we looked at treating patients on an expanded access, which basically replicated effectively the winning arm on the pivotal trial of midostaurin, what's called the RATIFY trial. And on RATIFY, patients got Daunorubicin and Cytarabine plus midostaurin during induction, high-dose Ara-C, and then maintenance therapy after they completed induction and consolidation. What was different about the expanded access was it gave us much more ability to tailor the use of midostaurin to our usual practices, not exactly what was prescribed on the pivotal trial, meaning we could use a higher dose of Daunorubicin, which was allowed. We could adjust the dose of Ara-C, which was allowed. We could give it to patients who were older than the upper age cutoff for the study, which was only up to age 60. And what's useful about that is we actually gained safety data about the drug outside of what the population studied initially was, and know that, yes, you can give midostaurin with patients at a dose up to 90 milligrams per meter squared of Daunorubicin without an obvious increase in toxicity. Yes, you can give this drug to patients over the age of 60, and we expect that will provide them a clinical benefit. And it's both tolerable, and also we see that they have a valuable survival, safety data that we are pretty happy with. So it gives us useful information in terms of saying how does this match with clinical practice, not just within the tight constraints of a clinical trial. And it gives me more confidence to do what I would ordinarily do, which is to say, well, I want to treat my patient with this regimen. Can I just drop in midostaurin to what I'm already doing and expect that it's going to be tolerable and expect that we'll see a clinical benefit from it? And I think the answer from that is yes.